Good morning, everyone. My name is Dr. Anand Sardesai. I work as a consultant anesthetist at Cambridge University Hospital NHS Trust in Cambridge, UK. And my job today is to tell you how we can use ultrasound to block sciatic nerve. First of all, I would like to thank the organizing committee of AORA for inviting me and giving me this opportunity. I'm sorry I can't be with you in person because of the pandemic, but I'm hoping I'll be able to meet you in future. Now, no talk on regional anesthesia is complete without little bit of anatomy. Now, in this picture, you can see on the right hand side, gluteus maximus muscle, and on the left hand side, I have removed this gluteus maximus muscle to reveal sciatic nerve. Now, as you can see, it has a pretty long course, and also it is one of the largest nerves in the body. It's formed in the pelvis by lumbosacral trunk, which arises from L4, L5, and also the spinal nerves S1, 2, and 3. It's formed in the pelvis in front of the, and it exits the pelvis through the greater sciatic foramen and emerges underneath this muscle over here, which is the piriformis muscle, and then it passes between the greater trochanter and the ischial tuberosity, and as it does that, it lies over the quadratus femoris muscle, which is the muscle over here. Then it enters the posterior compartment of the thigh, and in the posterior compartment of the thigh, it lies between the hamstring muscles, which you can see on the right hand side, and the adductor group of muscles. In the popliteal fossa, the sciatic nerve will then divide into tibial nerve and the common peroneal nerve. So what does sciatic nerve innervate? So sciatic nerve is the main nerve below the knee. So it will carry the majority of sensation from below the knee, as well as supply the muscles below the knee. Femoral nerve does not supply any muscle below the knee, and it only supplies skin on the medial aspect of the leg and the foot by its terminal branch, which is the saphenous nerve. But the rest of the sensation below the knee is carried by the sciatic nerve. Sciatic nerve also supplies the posterior aspect of the hip and knee joint, and it also supplies the hamstring muscles, which lie in the posterior compartment of the thigh. So when do I block sciatic nerve? So sciatic nerve can be blocked proximally around the hip joint. That is for surgeries on the knee joint. So any major surgery on the knee joint, like knee replacement or a bow knee amputation. Whereas you can block the sciatic nerve more distally around the popliteal fossa for surgery on the ankle or on the foot. But if you block sciatic nerve at the level of the popliteal fossa for foot surgery, then you will cause foot drop. And if the patient is a day case, then you won't be able to send him home. So the main indications in my practice are for knee replacement and surgery on the ankle, like ankle fusion, triple fusion, subtalar fusion, that kind of thing. So how much volume do I use? So majority of the time I use about 20 ml of local anesthetic, and depending on why I'm doing the block. So if I'm doing the block only for analgesia, I use 0.125% concentration. And if I'm doing the block for anesthesia purposes, so I'm going to do the surgery just under a block, then I'll use a more concentrated local anesthetic. So sciatic nerve is a big nerve and has a long course. So you can block it anteriorly by anterior approach, or you can block it by various posterior approaches as well. So in my practice, I use anterior approach quite often. So the advantage of anterior approach is you can do femoral block, and without turning the patient, you can do the sciatic block as well. And I also block the sciatic nerve by posterior approaches many times, but I never use parasacral approach, so I'm not going to talk about it, but I'll talk about the other three approaches. To start with, let us look at the anterior approach. So here you can see the human body. Removing the superficial layers, what it will reveal is the hamstring muscles, or the quadriceps muscles. I've highlighted these quadriceps muscles. So I'm going to take away the quadriceps muscle, and that will reveal the adductor group of muscles lying underneath the quadriceps muscles. I've highlighted the adductor group of muscles, and I'm going to take them away. And that reveals the hamstring muscles, which are the posterior group of muscles. And lying between the adductors and the hamstring is the sciatic nerve. To block the sciatic nerve from by anterior approach, a curvilinear probe is placed over the thigh like this, in the middle portion of the thigh. Now in this picture, you can see cross section of the thigh. This is anterior, this is posterior, and this represents the ultrasound probe. You can see various muscle groups in this cross section of the thigh. So anteriorly, you have the quadriceps group of muscles. In the middle, you have the adductor group of muscles. And posteriorly, you have the hamstring group of muscles. So when you're looking from anterior posterior direction, the sciatic nerve is found between the second and the third group of muscles. So between the adductors and the hamstring group of muscles. To block the nerve, I will stand on the side of the block. The machine will be on the opposite side. So everything is in line. So I can see everything happening in front of my eyes, and I'm not twisting and turning. The probe that I'm using is a curvilinear probe. Needle is inserted in plane. And this is what I'm hoping to see. So I'm hoping to see a shadow produced by the femur, femoral artery, femoral vein, femoral nerve here, and three groups of muscles here. So first group is the quadriceps group of muscles. The second group is the adductor group of muscles. And the third group is the hamstring group of muscles. So the sciatic nerve, which is here, lies between the second group of muscles that I see from anterior and the third group of muscles, which is the hamstring group of muscles. The needle is introduced in plane, and so you'll see the needle coming in that direction and then stimulating the sciatic nerve and depositing the local anesthetic around the sciatic nerve. So in this video, you can see the shadow produced by the femur. You can see the three muscle layers. You can see the sciatic nerve here, and you can see the femoral artery over there. Just to confirm the presence of sciatic nerve, I've turned my probe through 90 degrees. So it's lying along the long axis of the nerve, and you can see the sciatic nerve longitudinally in this. Turning the probe back on to gain the short axis view of the sciatic nerve. Then the needle is introduced in plane. You'll see the needle coming in from this direction. I'm using nerve stimulation as well, and you can now see the needle quite clearly. You can see the twitches. And then I'm going to deposit the local anesthetic, which will surround the nerve quite nicely. So once the local anesthetic is deposited around the nerve, you can turn your probe through 90 degrees again to view the nerve in the longitudinal section. And here you will see that the nerve is now nicely surrounded by local anesthetic on either side. Of course, you can block the sciatic nerve by posterior gluteal approach as well. So in this, a curvilinear probe is used again, and it's so in this picture you can see on the right hand side the gluteus maximus muscle, and on the left hand side I've removed the gluteus maximus muscle to reveal the sciatic nerve coming out of the greater sciatic foramen, going underneath the piriformis muscle, passing between the greater trochanter over here and the ischial tuberosity over here, and at this point is lying over a muscle called quadratus femoris muscle. Now all of this will be covered by the big gluteus maximus muscle. So to do it, the patient lies on their side with the side to be blocked on top. The anesthetist stands behind the patient. The machine is in the front of the patient. Needle is introduced in plane. So everything is now in line. So no twisting and turning. And anesthetist sees everything that's happening in front of him. The probe is placed over a line joining the greater trochanter and the ischial tuberosity. So what the anesthetist is hoping to see is the gluteus maximus muscle, the bony shadow produced by the ischial tuberosity, greater trochanter, quadratus femoris muscle, and the nerve lies between the gluteus maximus and the quadratus femoris muscle. So again, patient lying on their side, greater trochanter, ischial tuberosity. That's the probe placed along the line between greater trochanter and ischial tuberosity. That's the path of the nerve. So let's see what it shows. So here in this picture, you can see the bony shadows. These are the bony shadows produced by the greater trochanter and the ischial tuberosity. You can see the gluteus maximus muscle and the quadratus femoris muscle, and the nerve lies between the two muscles. And just to confirm the presence of the nerve, you can turn your probe through 90 degrees to view a longitudinal view of the nerve. Needle is introduced in plane. So here you can see again the bony shadows produced by the greater trochanter and the ischial tuberosity, muscle shadows of the gluteus maximus and the quadratus femoris muscle, with the nerve lying in the middle between the two. The nerve usually lies closer to the ischial tuberosity than the greater trochanter. Needle is used in plane, so you can see the needle approaching the nerve. The nerve is just over here and the needle is coming from this side. I use nerve stimulator always because it's a deeper block, and I like to have the additional safety feature of a nerve stimulator. Now, depending on where you are in relation to the sciatic nerve, the response that you see varies. So if you are nearer the tibial component of the sciatic nerve, you will see plantar flexion. If you are near the common peroneal component, you will see dorsiflexion. And sometimes you see inversion where you are stimulating both the nerves, both the parts together. Now the sciatic nerve can be also blocked by subgluteal approach. Now this is the gluteal crease, and the probe is placed just below the gluteal crease in the middle of the thigh. So here in this picture, I have removed the hamstring muscles on the left hand side to reveal the sciatic nerve. The gluteal crease is around this area, and the probe is just placed at there, just underneath the gluteal crease in the middle of the thigh. Now you're familiar with this cross section of the thigh. This is anterior, this is posterior. That's the quadriceps, adductors, hamstrings, and the nerve in the middle here. Now, when you're doing posterior approach to the sciatic nerve, the patient lies on their front. So I'm just going to invert this cross section so that now this is posterior and this is anterior. And sciatic nerve is here between the hamstring muscles and the adductor group of muscles. And that's where our probe is going to be. So you can use a linear probe for this because the nerve is not that deep. So you can use linear probe for this. The nerve is not that deep. Again, everything is in line. Needle is introduced in plane. Now this video here is made by two of my anesthetist friends from Nottingham. They've done a block for educational purposes. So they're using linear probe. And you can see the sciatic nerve here quite nicely between the hamstring group of muscles and the adductors below. So the needle is introduced. So they're doing this block while they're awake. So they're putting some local anesthetic in the skin. Needle is introduced in plane. So you can see the needle as it approaches the nerve. You're aiming for the fascia containing the nerve. So you're not actually aiming your needle towards the nerve, but you're aiming your needle to the corner of the nerve and putting local anesthetic in the fascia containing the nerve so that the local anesthetic surrounds the nerve. Okay, so you can see the local anesthetic spreading quite nicely around the nerve. So the needle is not actually directed towards the nerve, but slight tangentially or around the fascia containing the nerve. Beautiful. And the last approach is the popliteal approach to the sciatic nerve block. Now, popliteal fossa is a diamond-shaped region at the back of the knee. The superomedial boundary is formed by the semimembranosus and the semitendinosus muscles. The superolateral boundary formed by the biceps femoris muscle, and two heads of the gastrocnemius form the inferomedial and the inferolateral boundary. And in the popliteal fossa, you have the popliteal artery, popliteal vein, and the two branches of the sciatic nerve, tibial as well as the common peroneal nerve. This is where the popliteal crease is, and the sciatic nerve divides at a variable distance above the popliteal crease into tibial nerve as well as the common peroneal nerve. Now, where is the best place to inject local anesthetic? Now, studies have shown that if you inject a local anesthetic around the individual components of the sciatic nerve, so as the sciatic nerve divides into tibial and common peroneal nerve, if you inject local anesthetic around them, then the onset of the block is faster because the nerves are smaller and you have a more surface area. So when you inject your local anesthetic, the local anesthetic acts quickly around the individual components. Whereas if you inject around the sciatic nerve, because it's such a long, big nerve, the local has to diffuse through the entire nerve to block it. So always inject at this level where the nerve has divided into individual components. Now there is another concept called as a paraneural sheath. So just taking you back to the basic physiology. So each nerve fiber is surrounded by the endoneurium. A group of nerve fibers forms fascicles, and these fascicles are surrounded by the perineurium. And the different fascicles come together to form a nerve, and the nerve is surrounded by the epineurium. So in sciatic nerve, there is another sheath which surrounds the sciatic nerve, and this sheath is made up of loosely arranged connective tissues, and it's called the paraneural sheath. And this paraneural sheath envelops the sciatic nerve. Now, let me give you an example. So this gentleman is wearing skinny jeans. If you consider this gentleman's waist to be the sciatic nerve and the legs to be tibial nerve as well as the common peroneal nerve, then his skin is what the epineurium is, and the jeans that he's wearing is the paraneural sheath. So this paraneural sheath is closely adhered to his waist or around the sciatic nerve, and also closely adhered to the tibial as well as common peroneal nerve. But just where the sciatic nerve divides into tibial and common peroneal nerve, it's slightly loosely arranged. So there is a space here, a potential space, which is the subparaneural space, where if you put your needle in and inject local anesthetic, then you will be able to fill this space quite nicely, and that local anesthetic will spread up and down the sciatic and the tibial and the common peroneal nerves. So just looking at it here, so this is the tibial nerve, this is the common peroneal nerve, that is the paraneural sheath. These are the muscles surrounding the tibial and the common peroneal nerve. So the muscles are surrounded by the membrane, which is the epimysium, and this is where the paraneural sheath. So there are two potential spaces. One is the subepimysial space, and the second is the subparaneural space. So our aim is to deposit local anesthetic in this subparaneural space. So this is how I position myself. So everything again is in line. My needle comes in from lateral side, and I'm aiming to introduce my needle so that the tip of my needle is in the paraneural space between the tibial nerve and the common peroneal nerve. And here so my needle direction is also tangential to the nerve. So I'm not aiming for any nerve, but I'm aiming the needle tangentially, and I'm aiming to get the tip of my needle in the subparaneural space between the two nerves, and then depositing local anesthetic there in the hope that it will spread around both the nerves quite nicely. Just in case it doesn't, then I will redirect my needle and deposit local anesthetic so that both the nerves are nicely surrounded by local anesthetic. So in this video here, you can see a sciatic nerve, and as I move my probe caudally, you'll see the sciatic nerve dividing into tibial and common peroneal nerve, and you can see the paraneural sheath quite nicely as the nerve divides. So these are the tibial and the common peroneal nerve. In this video again, you can see the tibial nerve as well as the common peroneal nerve with the paraneural sheath around the nerve. My needle is coming from lateral side, and I'm aiming the needle tangentially between the two nerves, and then depositing local anesthetic in that space so that in the hope that it will surround both the nerves quite nicely. You can also see my needle is slightly bent here, and that's artificial. That's called bayonet sign. And that happens because the ultrasound passes at different speeds between different tissues. So it's not actual bend, but just ultrasound artifact. Now you can see that both the nerves are nicely surrounded by local anesthetic, but I'm also want to put some local anesthetic on top of the common peroneal nerve. So again, aiming it tangentially and depositing local anesthetic in that region. So are there any questions? So thank you very much for listening to me.